Welcome to episode 5, part 1, sex pain.
Yeah.
Sex pain.
We done with pleasure.
We're done with
No,
pleasure,
kidding.
but it's important to address sex pain to get to the pleasure.
Mm-hmm.
I'm Dr. Leslie Worth, certified sex therapist.
And I'm Dr. Kelly Frank, a pelvic health physical therapist.
Sweet. So I think this is, while I deal with the psychological side, you deal with the physiological side. So vaginismus, vulvodynia, dyspareunia.
Yes.
We're not in Harry Potter.
No.
What are these things?
So I consider them just more names. Like I don't want my patients to kind of feel confined by their diagnosis, although diagnoses can be very helpful for patients
For treatment
and kind
planning.
of feeling seen, feeling heard. So vaginismus is just, I kind of consider like the Venus flytrap of like the vaginal disorders, where it's the actual like muscle spasm. Like those tissues, those muscles are just saying, nope, this is not going to happen.
Right.
It can happen, at different times. Like we might see that with, as early as like tampon use, gynecological exam, speculum exam, and then absolutely any kind of like penetration, possibly with the penis or a toy or something like that. Vulvodynia is the actual outside of everything. So that's the vulva is everything on the outside. We talked about that. The vagina is everything on the inside. So that vulvodynia is disorders kind of the vulva. So just pain with wearing underwear, pain with touching. Some patients can't wear like jeans.
And it could be like an itching,
burning. Be an itching, burning. We kind of think of those like more nerve words. Like any kind of like electrical sounding word is more of a nerve word. The vaginismus is more of like a tight, ache, muscle spasm. So that's kind of more of that muscle word.
Right.
And then dyspareunia is just, pain with intercourse, pain with penetration, pain. It's just describing kind of what that is. And then again, that could be a little bit vaginismus. It could be a little bit vulvodynia. It could be kind of both.
Sure.
It could even be kind of going the other direction, like anismus, which is just like spasms of the anus, which kind of like leads us into, constipation, bowel problems.
Right.
Things like that.
Right.
Yeah.
So dyspareunia kind of can be like the umbrella.
Kind of the umbrella.
That kind of all these things fall under.
Yeah. And you might even get like diagnosed by a certain physician with one thing, and then you get evaluated by a pelvic health physical therapist, and they're like, oh, okay, yeah, I do think it's, but even then the muscle spasm, like, why is your muscle spasming?
Right.
Is there a pressure dysfunction? Is there a hip weakness problem?
Right.
Is there a core weakness problem?
Is it a psychological problem?
Is it a psychological problem? Right. And even if it's maybe not initially a psychological problem,
it will become
it's going to become a psychological problem, because now, again, you've probably, for the patients that I see that are not, the Gen Zers, like they have had this issue for several years. They have had it for several decades, and they have been told by so many, probably partners, maybe family, doctors, and other medical professionals, that like it is, in your head, or there is nothing wrong with
Especially
you.
if it's a psychological thing of intimacy. Like I get white coat syndrome, like a heart rate goes up and all that stuff. But what shows up in the doctor's office may not be showing up in the bedroom. Kind of like, my car makes the funny noise at home, but as soon as I get to the mechanic, it stops. So if it's like nervous about being sexually intimate or that kind of stuff, especially if it's like vaginismus and tightening or that stuff, it may not happen. Right. Or I've had some clients too don't think it's vaginismus because they can wear tampons, they can do these things, and I'm like, it's not from my understanding, it's not an all or nothing. It's not like it's always tight. It can be tight in different scenarios.
And even positions too, because like that's something too. It's like you don't maybe have to have, like if you just had a really awful first, gynecological exam where your legs are up in the stirrups, or maybe you haven't had that, but it was a really difficult birth, and then like coming back into sex and like you want to be in like that kind of like rote missionary position, like, God, that is like wildly reminiscent of this really awful thing that happened to me.
Right.
And my body's going to kind of remember, like, this is a hard no.
Right.
Yeah.
Exactly.
So having to kind of like differentiate that again between like how's your body like physically and then like mentally kind of reacting to that. And I try to have my patients, if we're able to, do different kind of therapies, like physical therapies, stretches, exercises, use with different tools that we'll talk about a little bit later.
Sweet.
But then I kind of also consider I want more kind of like wins
Right.
their belt of like, instead of just saying, okay, we'll just keep trying
Right.
and nothing changes. You didn't
Right.
change. You didn't change the physiology of it. You didn't change the actual tissue of it. You didn't change the mentality of it. You're just kind of hoping that this is going to be better
Right. Right.
with no change, with
Definition
no
of
help.
insanity, doing the same thing over and over again, hoping for
Yes.
different results.
Yeah. Yeah. So, yeah.
And with the pain too of you said nerve pain, and I read the book When Sex Hurts, which is a fantastic resource for non-medical, you know, textbook kind of thing. But they were talking about like the different what could be triggering it. Some of it could be tied to nerves and getting really, it's like the root of the pain is important so you can treat it
Yeah.
most effectively.
Yeah. And I try to refer a lot of my patients to sex therapists or like mental health therapists, like who specialize in talking about this, like very openly and comfortably. Because it might not be the things that we kind of like assume caused this pain, which, you know, obviously could be like a sexual trauma, an abuse, you know, some kind of like relationship or something like that. But even just again, like in our day, like different stresses, tensions, just how the world and how we are perceiving the world.
Right. And it's really important because I've seen it where it's going back to say keep trying and without actually changing anything for the male partners of penile fractures if they're trying to bust the door open.
Yeah. Our bodies are very strong. Our bodies are very strong and very capable. And I always kind of consider it too of like your body, if your body is doing everything in its power to physically tell you no.
Right.
Like, you need to listen to it.
Yes.
Like, there's probably been some little alarms throughout the way, and we probably like snoozed, and then there is going to be something.
Right.
You know, whether it's just full pelvic pain, issues with, you know, like maybe it's going to go up to the bladder, down to the rectum, like we're going to have peeing problems, pooping problems.
Right.
It could even kind of come up in jaw, headache, tension, like just kind of the rest of your body, when something's wrong, it is telling you.
And then also of we're talking about like inexperience, we don't know what sex is supposed to be like for male clients of like, it shouldn't feel like you're trying to really force your way in, right? You know, of with that and even just normalizing that too of like, if you feel like you're actually hitting a wall or if it feels like it's too much of like, stop, like there's something
exactly
going on.
Patients say like, I feel like, they're hitting a wall. Or if they are working like with dilators, which are different like kind of tools to help, you know, help teach the muscles to relax or to calm down. They say like, I feel like I'm hitting like a wall.
Right.
And then we even see it too, kind of like on sort of a different angle of that. Like if you're postpartum, I think they're very much doing away with it, but it was very popular, that husband stitch to make something tight. So going back to like that social media or like that context of this is desirable,
right,
to have a tight, you know, small, narrow vagina, you know, that vaginal canal. And it's like, but is it healthy? Does it function? Like,
right.
Does it move?
Right.
Does it have the ability to respond? You know, and so if it's now physiologically sutured,
right,
to be more narrow,
right,
and you're expecting tissue that once was able to move a little more freely,
right,
you physically created a difference in that. Yeah. So I mean, that's hopefully, I mean, they're doing it, you know, I see it less and less and less.
Sure.
But again,
or even healing from an episiotomy, you know, like your body tissue and all that stuff is going to be different and changed, and also going with the nerve pain or stuff like that. You may have pain where you didn't have pain before based on your childbirth experience.
Yeah. Yeah. And so working with, I mean, obviously I'm super biased because I am a pelvic health physical therapist, but, you know, again, like, this is not normal. Like, I think every time I talk to a client on the phone, they're just like, well, I mean, I have pain with this, but like, I don't know, is it normal at this stage, or, you know, is it 6 weeks or 6 months or 6 years, you know, postpartum? And the answer is like, no, like, pain's not normal.
And I told my clients that too, of like, pain is not normal unless you're welcoming it in a kink BDSM kind of environment, but we're still being safe, but just the mechanics of sex, tab A, slot B, should not be painful.
No, absolutely not.
No.
Yeah. So dealing with that from a physical standpoint, an emotional standpoint, and I think, coming back with the communication, education.
Right.
of just why is it this way? How can we fix it? What kind of specialists need to be, you know, not in the room, but
Right.
like,
And
yeah,
had to
on
have
your
those
team.
conversations too, right? Back in the book, When Sex Hurts, I really like that book because it gives the reader tools of how to talk to your doctors or how to advocate for yourself to
Yeah.
find the right the physician or therapist or whatever you're looking for, and not just be shut down if you're going to a gynecologist who's maybe not as well versed in these
Yeah.
issues, but that you're not crazy, but this is real,
Yeah.
and the pain is real, and it's not something you just need to learn to live with.
Yeah. I just think people just don't talk about it. It's just not something that you ask in either like your annual exam, or like you said, like you kind of just
Right.
like shut down during that exam and will grin and bear it because like I know I have to do this like every year to check for cancer, and it's like a health, it's a safety thing, and you don't stop and say, you know, that really did hurt. And if your legs are up and you have a little sheet there and like the doctor can't see your face, like I do a
Right.
really, I try really hard to like, if I have little mirrors around the room so I can kind of like just see their face, like I put
They
my
wince.
hands on their hips, I put my hands on their stomach, like I can kind of feel like if I do something or if they even kind of just like that dissociate, like shut down. Like I've had
Right.
several patients just, you start touching on an area, I'm always telling them exactly where I'm touching, when I'm touching, why I'm touching. It might just sound redundant, you know, if they're not having
Sure.
any pain, I kind of sound like an idiot because I'm like, is there any pain with that? Is there any pain? Like, you know, how are you feeling with that? And
Sure.
we kind of say it over and over and over again, but I'm kind of like half waiting for them to just like kind of get quiet, glazed.
Right. Well, going back to
You
they're
know,
snoozing those things, right? They're not paying attention.
And then they're trying to like just like, you know, it's like our first time meeting, so it's our new relationship, and so they're trying to like kind of not impress me, you know, or like, you know, we're both
Right.
trying to impress each other and
Sure.
and be like that.
It's like me squinting at the eye
patient.
doctor. I can see it. It's like, why am I squinting? Like,
Right, like, they're
I'm
just
not going to
trying
get
to
the right
help you.
prescription if I
They're,
squint.
they're just trying to help you. Yeah,
Right.
like you don't get extra brownie points
No.
for like lying to your
Right.
doctor or your therapist.
Right.
You'll just get the help you need.
Right.
And you know, can we talk about the spectrum of pain in a sense? Because they say that, you know, tickling is the lowest form of pain, so to speak, right? Or people that maybe have celiac disease or whoever it may be, right? Or just an intolerance. You've lived your entire life just saying, you know what, when I eat bread, I get bloated and gassy, and it's normal, right? But then you find out that, oh, I didn't have to have this, right? So can you talk a little bit more about the spectrum of pain? Because I'm imagining it's not like, ow, you know, you're talking about every single time, right?
Right.
Yeah. Yeah. Well, I think from like the PT standpoint of it is finding, like really having my patients like clue in with me. Like if I'm asking you for this pain or just the sensation, like again, it might not be pain. Like, do you even feel my pressure? Can you
Right.
feel the touch? Like if my hand, can you feel that it's cold? Can you feel that it's warm? And we kind of call that like the retraining of those nerves and
Sure.
tissues, like desensitization.
Right.
And so from our perspective is you might feel something, yeah, to a degree, and then it might change or stop or, you know, get worse, better,
Right.
nothing.
And I do the same with the mental side of things. Of if you're so in your head or disassociating or wrapped up in intrusive thoughts, of this works like grounding or mindfulness, or like I love like body scans, right?
Yeah.
Progressive muscle relaxation of like, I know every time I do it, it's like, you know, I get to the point where it says tense your shoulders. I'm like, well, they've been tense. I don't know how long, but you know, apparently I have no neck today. And then what does it feel like to really relax that? Like, and training yourself of like, what does it feel to drop your shoulders and to relax? Or I think you said a couple of episodes ago of like, stop clenching your butt.
Yeah.
You know, like what does it
Yeah.
feel to relax those abdomen muscles and your glutes and your hamstrings and all? What does that even just feel like? So you even know kind of what your question is like on that spectrum of pain. What does relaxed feel like? So you have that baseline of like, well, this is what relaxed feels like. And it might not be pain at first, but do you start to feel it tense?
Yeah.
And then that can, because I feel like, as you always say, Kelly, pain is the fire alarm. Your
Yeah.
body is like, hello, something is not right. And are we ignoring those? It might be tension first or slight discomfort before we get to that actual pain.
Yeah. And if we're
response.
living with chronic pain or we're living with like that chronic tension, it's I have like an elevator. I think a lot of PTs was like an elevator kind of analogy of like you might be living between like the first and second floors
Right.
of this building, which can be helpful if like that is where you live.
Right.
But if you want to go anywhere, you have to get to the ground floor. Mm-hmm. And so the idea of like that, muscle tension before relaxation, sometimes if you only know this like little bit of up, but you can find it. Like, well, you can find, my upper trap. Like, let me find it, and then can I go further down?
Right.
Which for some people might feel like, in relation to the pelvic health, like it might feel like you're pooping,
Sure.
or you're farting. Like this is way lower than I thought I should be, and then we have to kind of come together and be like, okay, well, what is like the happy ground in the middle? You know, we shouldn't be living here on the first floor. We don't want to live in the basement either.
Right.
We have to kind of like, be at that ground floor, and then our body will learn to, when we need to go up to the first floor or we need to go to the basement, we can kind of get there for different just daily functions.
Right.
But then, for intimacy, for sexual experiences, which way we want to go.
Right. Right. And the pain too of it's the awareness first, I think, is all that of just like we say this all the time of like, are you even aware of what's going on with your body versus getting those alarm all the time, and are you clued in? And then if you are getting those alarms, stop. Like, don't keep pushing it. Like
that's the American way, right? That's the American way. We have to keep going, keep driving, keep
like if a fire alarm's going off, I'm not running into the building.
No.
Hopefully, I'm trying to find the exit. And that's the same with us of like, don't keep going further into what's causing pain, but pause and then maybe try to connect with yourself of where is the pain? Because sometimes you just feel pain, but you can't really identify, going back to the difference between like vulvodynia or vaginismus, like, is it internal? Is it external? Is it both? Is it like, and then that can help you figure out the best course of action or go to physical therapy or wherever.
We'll find the firefighter, find the person that's like equipped, has the tools, has the things that can actually help put the fire out if it is a fire. And then there is like, the investigators. So you need like the firefighter and the fire investigator to kind of be able to, all right, we've got
piece
our
it
PT,
together.
We've got our sex therapist, like this is where the fire was, but why did we kind of get there?
Right. Which I think is great for part 2. We're actually going to get into of our techniques and what we actually do for people once they identify what's going on.
That they have pelvic pain.
Yes.
Awesome. So we'll see you for part 2.
Stay tuned.